access kit, so the big white box. You need to bring the external CSF drainage system right here.
Okay.
You'll need to bring a trauma catheter or the EVD catheter. So this trauma catheter, or if the doctor wants to put a antibiotic embedded trauma catheter, it would be the Bactiseal. You'll also need to bring supplies for the insertion. So you need to bring the sterile towels, mask. You have to ask the doctor what size gloves they are, sterile gloves, cap, surgical gown, the surgical clippers, and a razor. If the doctor wants to transduce the ICP using the EVD, you'll need to prime the AccuDrain or the external CSF drainage system, so please bring this, your size sterile gloves, a sterile normal saline syringe, and a transducer, as well as a pole. So you need to wash your hands, put on your, oh, not that. Open the AccuDrain system. Inside you'll find the leveler, the line lever, and this is what you're going to use to level the EVD to the EAC. You'll find the drainage system. Inside is the CSF drainage bag. This stays in the plastic bag because this will be the sterile connector to the patient. And you will need to make sure it's secured. You need to prime the AccuDrain. So first, prime the transducer. And by doing that, you'll need to connect it to the AccuDrain. Make sure that the connection's well. Once you connect the transducer to the drainage system, you have to connect the sterile saline syringe to the connector here. You turn it off to the drainage bag. These arrows will be pointing towards the system and towards you, so you know that this site is open, and you can go ahead and flush onto you. Then you make sure you close this port so you know that it's sterile and nothing will come out. You will change out this white port with a yellow cap. What's this one? So this side is primed. Now you're going to prime the drainage system itself. So turn it off to the transducer, and you can prime it towards the drainage system first. So off to the patient. Go ahead and prime all the way through. Make sure there's no air bubbles. And once that's done, turn it off to the drainage system, and then you'll prime it towards the patient, which is not connected yet to the patient. You're just setting this up. So you go ahead and prime it until you see that it is all the way through. You'll see there's a little drop there. You have to make sure there's no air bubbles because that will interfere with an accurate ICP reading. Once that's done, turn off the system towards the syringe. Make sure the system is closed. So you want to keep the yellow cap on. And then you can make sure that this is empty of all the saline so you don't add any like CSF output with the saline. So make sure that it is off to the AccuDrain. And you will have to wait for the doctor to insert the drainage system or insert the EVD. So once he's done, he'll let you know when he's ready, and you can take this off for him and just hand it to him because this part has to stay sterile.
So this is an externoventricular drain or trauma cath. It's a slightly larger diameter externoventricular drain, and it's typically used for trauma patients. It's obviously a non-sterile box, so you would help us open the box, pass us the non-sterile bag, open this for us, and then with my non-sterile gloves I will be able to take this out. And obviously I would have my sterile field here already. And what the trauma cath has is very simple. It's just this trauma catheter with a stellette inside and a trocar with a very, very sharp point. And I always urge the provider to clear all their sharps from the field before they leave the room. And it also has some connectors and some stops to, if you want to cap off the catheter. So that's what the trauma cath has. So we're now going to talk about the actual procedure of inserting a externoventricular drain. This obviously will be done by the provider, and more importantly, I will highlight what you as assisting us need to do for us. So the patient is well positioned and the hair is shaved already. We've already prepared the scalp, typically with betadine, and now we drape the patient. So the kit comes already with the drape, so you don't need to put any, take any drapes for us. And typically it already has a hole in it, and it comes with a sticker, so it sticks onto the head. Let's do that. And once the incision is made, a self-retaining retractor is placed like this, and holding up the skin, we make our hole. So this is the part where you'll need to come and help us, because as we drill, the patient's head may move. This patient may not be fully sedated, semi-conscious, and they might even try and resist us with their hands. So this is an important part where your assistant is greatly appreciated. Make sure that you're nice and comfortable, that the bedside rails are down so that you don't hurt your back. But you need to be able to reach underneath the patient's drape and around the jaw so that you're stabilizing the head. When we're ready, then we can start drilling, and as we drill, we will let you know when we've stopped drilling so that you can actually relax back. So I've stopped drilling now. and you can relax back. The actual insertion of the external ventricular drain is based on anatomical landmarks. So ideally we place it into the right frontal horn of the ventricles. We will have an idea of how deep to go and when to expect a flashback of CSF. As we insert this drain, we get a flashback of some CSF, and we're able to remove the stellate from the drain and confirm egress of CSF. Once this is done, it's important that we continue the procedure without accidentally pulling out the EVD. And sometimes in difficult EVDs, we may even ask you to don on some sterile gown and gloves and help us hold on to the EVD with a non-abrasive and non-tooth forceps, so that when we're manipulating this, we don't accidentally pull out the EVD. The end of the EVD is then connected to the very sharp trocar, like this. The protector is removed, and the trocar is tunneled under the scalp. This is a painful procedure, so the patient again may wince, and it's very helpful for the assistant to make sure that the patient is well anesthetized, as well as analgesia is on board, but more importantly, to be near the bed and maybe to make sure he doesn't suddenly move or use his hands to stop us. So as we tunnel the tube, which I can't show you on this model, this part of the tube will be sitting under the scalp and will come out. As it comes out, we should be able to demonstrate the number in centimeters of tube that's exposed. It's important to note the number so that, again, whilst you're nursing this patient, we would know whether the tube has been moving out or not. As the tube moves out, the number decreases, obviously, and that might alert us to either troubleshoot the drain or explain why the drain's not working any longer. But we normally record what the number is and make sure that that number doesn't change relative to the exit point of the EVD. So once the EVD is in place, I then connect the end with the connector, which comes with the kit. This connector is then inserted here, and it's usually sutured for security so that it doesn't come out, and I normally cap it to finish off the procedure. I finish it off by securing the tube using 3/0 nylon, which sometimes comes in the kit and sometimes it doesn't, and if it doesn't, then these are the most usual sutures that we will need. And we also use 3/0 nylon to suture the incision. So once it's secured and we have this tube connected, we're now ready to connect to the reservoir. So the tip, which is sterile from the reservoir, is given to me. I'm able to then detach that and this, and to connect this. So this is now connected to the reservoir, and we'll discuss how to set up the reservoir correctly. So the EVD is now connected to the reservoir, and we have to put the reservoir at the required level. And this is usually specified by the neurosurgeon looking after the patient. The first thing we need to do is to make sure that the zero is at the level of the patient's external auditory meatus, or EAM. This can be done by altering the level of the pole. There are usually some squeeze tabs. That's right. And the kit sometimes conveniently comes with a spirit level. So we are going to lower this until we get the required.
Perfect.
So now the 0 here is level with the EAM, which means that every single time you move the patient, when the patient sits up or lies flatter, you need to make sure that that 0 moves with the EAM. And then the chamber needs to be at a level so that we drain it at a certain pressure. The pressure that we normally specify is measured in centimeters of water, traditionally, although it also has markings for millimeters of mercury. So when we set this up, typically we would then lower this chamber to, for example, 10 centimeters. And we should then be able to open up all the channels and stop the and open up the channel at the connection as well, and see egress of the CSF.
After the doctor places the EVD, you want to make sure that you have the chambered level to the order of what cms of water he wants it at. So in this case, Dr. Lee wanted it at 10 cms of water. So make sure that the Volutrol is leveled at 10 cms of water and that you have the order for that. And also you want to make sure that it's leveled correctly. So again, we have the leveler and you want to level it to the EAC. And you want to make sure that the bubble is right between the two black lines, which it's not right now. So in order to adjust it, you're gonna press on this little squeezy thing and level it to the EAC and move the AccuDrain up or down just to make sure it's leveled. So once you do have it leveled, you want to make sure that the AccuDrain is secure. So always have the string on to the IV pole and tighten it. And you also have in the back these rubber secure. So right now it's actually okay, but you want to make sure that it's still extra secure, so just re-snap it. You can still move the drain up or down, even with this secure system, but at least you also have this as a security system to make sure it doesn't completely fall to the floor. So you have to zero the EVD every shift, and to do that, again, you have to make sure that you're leveled. The EAC is leveled with the 0. So right now, the bubble is in between the two lines. And then you turn off the stopcock to the drain, and then you turn off the transducer to the patient. You remove the screw, and then you press 0, 0 ICP, and then once the number reaches 0 and says ICP 0 done, you can go ahead and reconnect the screw, turn the stopcock to that. This way, when the stopcock is pointing up off to the drain, it is giving you an accurate ICP measure. because it's reading off to the drain and reading the patient's pressure that way. Once you're done with the ICP measuring, remember to turn the stopcock off to the side so that CSF can still drain. To empty the chamber, make sure you turn off the drain to the patient, and then you use the yellow stopcock and turn it to the side where both arrows are leading so that the CSF can go down to the bag. And once that's done, always remember to turn off up to the chamber, and remember to open the drainage system so that CSF can flow back in. Before transferring the patient to any procedures, you want to make sure that the volume trough is completely empty. So remember to turn off to the patient, move the stopcock down to the side so that it drains to the bag, put it back up, open to the patient. The reason why we do this is because if the filter on top gets wet, it will cause the system to be clogged, and it will also be another risk of infection.